Welcome to London Valve 2025. My name is Lorenz Räber from Bern University Hospital, and it is my pleasure to introduce Kasper Korsholm from Aarhus University Hospital. We will talk about pre-procedural assessment for successful LAA occlusion today. Kasper, why at all should we do pre-procedural and not just intra-procedural imaging? It would be much easier just to order the patient and do the imaging in the cath lab. That would save costs and would probably be more efficient.
Thank you very much for the question, Lorenz, and it's an important question. First of all, I think we need to exclude LAA thrombus before going into the appendage. And then secondarily, the left atrial appendage is a very complex structure. It's very heterogeneous, so as opposed to other interventions, this structure actually differs for every patient we treat. So we need to do imaging to plan the intervention carefully to mitigate the risk of the procedure and overcome procedural complications, but also to obtain optimal procedural results.
That's a very important notion because obviously it's a preventive therapy and there is actually no tolerance for its safety, and as you say, the LAA morphology is highly variable and the approaches therefore differ. Can you tell us with which modality you would image the LAA upfront prior to the receiving the patient in the cath lab?
In our center, we use cardiac CT for pre-procedural planning, and I think that should be the preferred imaging modality. It's you have very high resolution data, and you can manipulate it in any way you want, and you can transfer it for proctoring if you want that, to get advice from colleagues if you have difficult procedures ahead. And I think that's important, and it's key that we carefully plan these procedures and not just do as we used to with 2D TOE. You need to be very diligent, as you say, it's safety first.
So you would give a preference to CT versus TE.
Yes.
Can you just in very few words describe the key advantage that CT may has in the planning compared to the TOE?
I think first of all there's the patient perspective, and CT is very patient friendly. So if patients have to undergo repeated TOE imaging, I think they prefer not.
They will not like it.
And secondary, there is the perspective of the operator, and there I think CT provides a roadmap for the intervention. You can visualize the transeptal puncture site, you can plan the access into the appendage, and you can pretty much plan anything you want. So therefore I would prefer CT, and you can use it to structured planning each step of the intervention and also the challenges ahead, and you can plan for plan A and plan B if so and so happens.
Absolutely. So we in Bern we do exactly the same. We routinely perform a pre-intervention CT, usually within 1 or 2 week maximum prior to the intervention. But can you describe us what are you exactly looking at the CT?
Yes. So first of all, we want to rule out LAA thrombus. That's my first task. And once that is ruled out, I would look at the appendage. And I use a structured approach. First, I look at the ostium, define the ostial plane. I measure the ostium. And then I look at the anatomy of the appendage. Are there any proximal lobes that I need to cover with the device? Are there any depth issues, so short depth of the appendage that may challenge the implantation of certain devices, or I need to select a certain device? Are there any trabeculations that may interfere with the device or my implantation technique? And I also look at the orientation of the appendage that may may do something for the axis into the appendage, and then finally I look at the transeptal puncture side. Where should I puncture to obtain a good axis into the appendage so I get coaxiality? And there it's a very good tool to use CT as well.
Excellent summary. Actually, I would like to come back to one of the issues you look at, because that's usually really the limiting factor, and that's the depth.
Yes.
So can you quantify it a bit? What means short depth?
So short depth is, as we look at it now, we look below 15 millimeters. I think that will affect which device you want to implant. And the depth of devices may change according to the size of the device as well. So there are variations according to which device you use or want to use, but 15 millimeters is the cutoff, where I would say below that.
Very good point. And finally, you mentioned the location of the transeptal puncture, which I, of course, fully agree is extremely important to get collinearity when we place the device, to get a good axis. So in a nutshell, what would you say in brief words, what is the key essential regarding the axis or the place of the puncture in association with the position of the LAA or the orientation of the LAA?
I think the most important thing is to go very inferior. That's the key, and then sometimes we can always go up. And then sometimes we change whether it's very posterior or more mid, depending on the axis of the left atrial appendage and the takeoff of the appendage, perhaps also.
Can you specify a bit? Is it more the anterior or posterior orientation of the
appendage?
Yes, regarding the selection of a more anterior localization of the...
If you have an appendage with a sharp bend going more anteriorly, you might favor a bit more mid or anterior puncture in order to get the coaxiality into the appendage.
Excellent. Thank you very much, Kasper, for this great summary. So in conclusion, we are really in favor of a routine planning by CT to avoid surprises and to make a preventive treatment and stroke prevention therapy as safe and efficient as possible. Thank you for listening.